So one of the things that we knew from an early study by, not early, actually, it was just a few years ago in the dental field, that Christy Victoroff, who's the Associate Dean of Dental Education at Case Western Reserve University's Dental School, did her thesis, and then later we published a paper that came out about a year ago on this, showing that the DAT, the dental admissions test, predicts grades in the first 2 years of the 4-year postgraduate experience called dental school, and those are the years in which the students take courses. But then in the 3rd and 4th years, in which they spend all of their time in the clinic, they're graded by 2 preceptors, faculty who are watching them and working with them, supervising them, that the DAT did not predict the grades in the 3rd and 4th clinical years at all. But she gave students in the 6th week after they'd come to school a 360, the earlier version of the ESCI, and they filled it out on each other. And others' views of each student's emotional and social intelligence demonstrated did not predict grades in the first 2 years of the courses, but did predict grades in the 3rd and 4th year in the clinic. Lauren Dyke looked at something that all medical students in the United States go through, which is usually in their 3rd year, the 8 standardized patients you have to satisfy and comply with in terms of the differential diagnosis in these 15, 20-minute segments. We had the benefit at our medical school of having very high definition recordings in these waiting rooms, the visiting rooms. And what Lauren was able to do was to extract from the videos that the degree of positive emotional attractors demonstrated by the medical student to the standardized patient, which often happened in them looking at them, them asking them questions. In one case, the presenting problem is a back pain. The person had to get up on the table. They helped them. They asked them if they were warm enough, if they wanted a blanket. Things which didn't deflect from the task at hand, but in fact made it a little more human. The alternative, which he coded as negative emotional attractor behaviors, where the medical student was sitting at the computer typing away, and occasionally would look over as they're typing the history, and was concerned about looking at their watch and doing those kinds of things. As you might guess, the positive emotional attractor behaviors predicted the standardized patient's evaluation of how well the medical student did, and how well the faculty, staff, physician evaluated it. Interestingly enough, the MCATs did not predict any of that. Actually, the MCAT scores were negatively related to this positive emotional attractor behavior. So what Lauren's thesis did was start to take the notion of the underlying emotional and social intelligence competencies and move it into the realm of how do we come across in a way which is more constructive in these processes. We know from our leadership research that when people are in an effective leadership relationship, which is often 10% at most of the leadership relationships in any organization, which is sad, but when they're in those relationships, they feel a sense of shared purpose or a common vision. They feel a sense of compassion and caring. They feel people are being authentic and mindful and tuned in. And often they actually experience a degree of playfulness. But all of that conspires to what Dan Goldman and Annie McKee and I have called a resonant relationship. Well, the resonant relationship, we know from our fMRI studies, even years later invokes neural networks that are a part of a person being more open to new ideas in terms of segments of the default mode network. Whereas dissonant leaders, the ones who are predominantly task-focused, metrics-driven, and always talking about something that isn't very human or kind of pushing people along, that those memories close down. They actually suppress those networks. In the healthcare setting, we had one of former doctoral students who was an MD also, Masood Khawaja, did a thesis in Pakistan trying to look at what affects treatment adherence for type 2 diabetics, those clinically diagnosed. Type 2 diabetes has about a 50% treatment adherence, both in Pakistan and the US, and actually, by the way, pretty much everywhere in the world, which is really a shame because it's eminently controllable. Well, not for everybody, but then this is type 2 diabetes. And he took all of the things in the medical literature about the doctor-patient relationship and how much the patient knew about knowledge about diabetes and all these factors. And about 5 of these factors statistically did predict treatment adherence, but 6, but all of them were mediated by the quality of the patient-doctor relationship as seen by the patient, which is why the patient experience has become so popular and such a common practice in healthcare these days. But it was specifically the PEA to NEA ratio of the doctor-patient relationship as seen by the patient, which was really striking. And the particular scales of the instrument that were the most powerful was degree of shared vision, degree of shared positive mood. So if we're to have a new level impact on healing, on having patients pay attention to what doctors and nurses would like them to do, the thing we can tweak the most is the quality of their relationship. Again, it comes back to, do you have the building blocks in your repertoire of emotional and social intelligence to pull that off?